So good morning once again, everyone. Today's journal club will be titled with implementation of an innovative surgical pharmacy service to improve patients' outcomes. It's a 12-month outcome of enhanced surgical medicines optimization service. Like I said, does anyone have like any idea about the term surgical pharmacist or the enhanced surgical medicine optimization service before we carry on with the presentation? Hello?
No, Muhammad.
Can you guys speak a little bit louder, please? Because I'm not able to hear anyone.
No, no.
All right, then. So basically, with this concept, uh, it evolves around the term surgical pharmacist, where a pharmacist gets involved preoperatively, perioperatively, and postoperatively with the sole aim of optimizing the medical treatment with respect to safety, efficacy, and rationality of the medication, and providing the patients with the most evidence-based treatment available. This paper was published in the Journal of Clinical Pharmacy and Therapeutics. It was accepted on the 14th of July 2019. And as you can see, these are the authors. It was done in the Center for Pharmacoepidemiological and Drug Safety, Department of Pharmacy, Manchester University Hospital, NHS Trust, UK. So we'll start with what's known and objectives of this article. As we all know, pharmacists play a vital role in medicines optimization in different care settings. Studies have shown that optimizing patients' pre-existing comorbidities prior to surgery leads to better post-operative outcomes. The enhanced surgical medicine optimization service, I'll be referring to this as Osmos throughout the presentation, so please don't get confused. It is an innovative surgical pharmacy service introduced at a large teaching hospital in the UK in 2017, which aimed to reduce the length of stay and post-operative complications in general surgical patients. So the purpose of this study we are going to review now is to evaluate the implementation and outcomes of this service at 12 months after it was rolled out. So I just want to mention something that before they start this study, there was a similar concept that was started by the NHS in 2013, where they did a study and involved 100 patients, and they grouped them into two groups, where one group had pharmacist intervention pre, peri, and post-operatively, and one group with no surgical pharmacist intervention. The group with the surgical pharmacist intervention had a reduced length of stay and a reduced rate of post-operative complications. So these are some of the important points in the introduction. I'll just go through them roughly. Um, Post-operative complications after major surgery are well documented in the literature, with complication rates as high as 30% having been reported. In line with the emphasis on both quality and cost effectiveness in the NHS, there is a need to reorganize the healthcare workforce to provide a multidisciplinary model of care with a focus on optimizing pre-existing comorbidities prior to the surgery. So basically, the NHS is the National Health Service in the UK. It's a type of insurance, trust-based insurance program where all the citizens of UK will be able to benefit from the free medical treatment services. And even those who are not citizens of the UK who live or are staying in the UK can also benefit of this free medical service. The goal of Osmos service are to identify high-risk surgical patients once they are listed for surgery and get them in the best possible state for operation by focusing on optimizing their pre-existing comorbidities. So during the preoperative phase, patients are reviewed in a pharmacist clinic whereby patients' pre-existing medical comorbidities are recorded by the pharmacist along with any high-risk medications the patient is taking. In the post-operative phase, all patients are closely monitored on the ward with the focus being on medicines optimization to minimize the incidence of any post-operative complication occurring. This involves working collaboratively with the wider multidisciplinary team, including anesthesiasts, surgeons, specialist nurses, dietitians, and physiotherapists, along with both pharmacists and general practitioners in the community. The Osmos was initially started with 4 main general surgical subspecialties: hepatopancreatobiliary, upper gastrointestinal, lower gastrointestinal, and vascular surgery. Each specialty was allocated one specialist surgical pharmacist with independent prescribing status, along with a pharmacy technician to support the service. So when it comes to the study design and data sources in this study, it was a retrospective cohort study conducted using a registry collected by the Osmos pharmacist prospectively during the individual patient admission. The registry included the following information: patient demographics, American Society of Anesthesiologists score for physical status. So basically, there was a score by the American Society of Anesthesiologists where other comorbidities and the current condition of that patient come into picture, and that score ranged from 1 to 5. Comorbidities, details of high-risk medications, nature of pharmacist intervention, post-operative complications, length of stay, and details of any readmissions. So in this, we can see the study cohort, all the adult patients who underwent major elective general surgical procedure with an ASA score, which is the American Society of Anesthesiologists grade of more than or equal to 2. During the study period were included. So as you can see, 554 patients were included. Then 273 were excluded because of being low risk patients. Patients enrolled in the osmosis. Then you can see like 271 patients were there remaining. Almost 21 were excluded because patients dropped out due to operation cancellation or disease progression. And then they were left with 250 patients, of which 4 were excluded because of missing records. Then the remaining 246 patients, they were grouped into vascular, which was of 60 patients, upper gastrointestinal, which were of 17 patients, hepatopancreatobiliary patients with 82 patients, and colorectal patients, which were of 87 patients. So when it comes to the outcome measures in this study, the primary outcome was the actual length of stay, which was calculated as a continuous time period of each patient inpatient spell. The nationally expected length of stay for corresponding major elective surgical procedures was also retrieved and compared with each patient's actual length of stay. The data analysis used was a descriptive data were used to report the results, including mean and standard deviation, or median and interquartile range for length of stay, and proportion for the categorical variables such as genders, age rank, and ASA grade. For each patient, the reduction in length of stay was calculated using the Wilcox sign rank test All data analysis was conducted by using an online software package, StatPage. So coming to the results of this article, the in this here we can see the characteristics of the patients in this table, which were mostly males, and most of them fell in the age group of between 60 and 69, with the following percentages and number of each category of surgery. And the most common comorbidity seen on those patients were mostly cardiovascular diseases. Coming to the most seen high-risk drugs, antiplatelets took the lead with 122 drugs, then anticoagulants with 49, and ACE inhibitors with 113. In total, there was almost 420 interventions undertaken by the pharmacist, including 186 interventions related to medicine optimization and 234 interventions related to perioperative drug management. So I just want to mention one point. The interventions in this study were categorized into two groups, which were medicines optimization prior to the operation and perioperative drug management, which is like perioperative. It represents that any drug adjustment or modification done around the time of surgery, which means like around the time, like let's say for example, the surgery is said to be take place like at 1 o'clock. So any intervention or drug modification that lies around that time, which is like starting at 11, 10 o'clock on the same day of the surgery, is considered to be a perioperative drug modification. So in this table, we can see a number of high-risk medicines by patients and the major pharmacist intervention. Here we have in the left column, we have the total number of patients and the number of drug taken by them, and the number of interventions with respect to each surgical category, and the number of medicines optimized with respect to each surgical category, and the preoperative drug management with respect again to each surgical class. So in the result, the reduction seen in the length of stay, we'll be looking at it in this slide. The median length of stay for the 4 surgical subspecialties were as follow. So these are the numbers that presents the actual length of stay. With regards to upper GI surgeries, the median length of stay was 20 days, with interquarter range of 11.5 to 32 days. And with regards to lower GI surgeries, the median length of stay was 8 days, and the range was from 6 to 11. And for pancreatobiliary surgeries, it was 11 days, and the range was between 8.5 and 15. And 6 days for vascular surgeries, with the range being between 4 days and 9 days. So then what the expected length of stay for each class of surgery was 14 for upper GI, 10 for lower GI, then 14 again for hepatopancreatobiliary surgeries, and 10 for vascular surgeries. So there was a significant reduction in the median length of stay in the lower GI surgeries, with a mean reduction of 2 days, as you can see here. I hope everyone can see my cursor. Hello? Hello?
Not exactly. We can't see your cursor.
So here you can, You can see it now. So you can see in the second paragraph, the mean reduction in the lower gastrointestinal surgeries is 2 days, and
Yeah,
there is a reduction in the interquartile range by 4 days. Then coming to the hepatobiliary, pancreatobiliary surgeries, there is a mean reduction of 4 days and a reduction in the range by 7 days. And in the vascular category, there is a reduction of 2 days and a reduction of 4 days in the range. The median actual length of stay was longer than the median expected length of stay in the upper GI specialty, which was an increase in the mean reduction with 5 days and a reduction in the range of 3 days. Although this result was not that much insignificant, significant because of the less number of patients. So overall, the total length of stay reduction in patients whose actual length of stay fell in the 25th to 27th percentile range was 96 days in the lower GI, 81 days in the hepatopancreatobiliary, and 104 days in the vascular subspecialties, which summed up to a reduction or a median reduction of 281 days. So as we can see here, guys, this is a pretty significant reduction in the length of stay, which is very important for an organization like the NHS, which provides medical treatment or free of cost. So you can see like the amount of cost that can be saved with this reduction, and the efforts of those general practitioners that can be focused more on patients who are at more serious conditions, and having a better quality of treatment with respect to those patients, and keeping them for a lesser time in hospital, which also helps with their treatment as well. So in this graph, we can see that there is a comparison between the expected length of stay and the actual length of stay. And you can see here, in terms of upper GI surgeries, there was a range between 11 days to 34 days, with the mean being more than 30 days, and the median being around 20 days. But this is like the actual length of stay, but in the expected length of stay, it's less. And like I said, this was attributed to the fact that most patients were less in number in this class of surgery. But in the lower GI surgeries, the mean was almost the same. The mean is represented by this dot, and this line in the middle of the box represents the median, and the box represents the range of patient stay in the hospital. So in this, you can see that there is a reduction in the median of patients stay in the hospital, and the hepatopancreatobiliary, there is the mean is almost the same, but there is a reduction in the median, as you can see here, represented by the line separating the box. And in the vascular class, as you can see, the mean is also the same, but the median is less. When it comes to postoperative complications, overall 118 patients experienced postoperative complications, and the proportion of patients who experienced postoperative complications was higher in the upper GI surgery group, followed by the lower GI and vascular and pancreatos-biliary surgeries. Of all the 275 episodes of complications, postoperative nausea and vomiting took the majority, with the most frequently identified surgery-related complications, followed by infections and cardiac issues. So this table represents the number of complications and the type of complications on the left column, you can see, and their numbers, I mean, with respect to each class of surgery. So coming to the discussion part, these are just a couple of important points that I have highlighted. We can see in this where they say, like, in this research, it was the first to assess the short-term outcomes of an innovative surgical pharmacy-led service model to enhance the surgical care. The results demonstrated a significant reduction in length of stay for service receivers in the lower gastrointestinal, hepatopancreatobiliary, and vascular surgical subspecialties in comparison with the corresponding expected length of stay by the national standard. The Osmos users had a significant reduction in length of stay compared with the expected length of stay in those within the lower GI, hepatopancreatobiliary, and vascular subspecialties, but not within the upper GI subspecialty. This could be due to the small patient number in this group. This is a point which I mentioned earlier as well. A reduction in the length of stay, a median reduction of 2 days was observed within those who received vascular surgery. The trust or the hospital is recognized as a tertiary referral center for vascular cases, and the service is strongly supported by a vascular specialist nurse who also referred patients to the Osmos pharmacist preoperatively. This streamlining of prioritization of resources may also contribute to this reduction in the length of stay effect observed. There was a substantial reduction in the length of stay with respect to those patients who underwent hepatopancreatobiliary surgeries. This could be also due to other interventions such as implementation of regional jaundice pathway to improve patients' outcomes, recruitment of a jaundice clinical nurse specialist, and the introduction of a prehabilitation program led by both a specialist dietitians. And for patients who received the lower GI surgery, a decrease in the length of stay with a median reduction of 2 days was also observed. This reduction was observed despite there being some disruption in the provision of lower GI services within the trust, with 2 stoma nurses leaving posts within the study period. In this study, 48% of patients who underwent a surgical procedure uh, developed at least one postoperative complication. The most frequently observed complication were postoperative nausea and vomiting, followed by infections and cardiac issues. Um, this study demonstrates the importance of multidisciplinary team. So this paragraph basically will be highlighting the importance of the pharmacist, the clinical pharmacist or the surgical pharmacist with respect to uh, optimizing the medical treatment to patients undergoing surgeries. So, like I said, this study demonstrates the importance of multidisciplinary team approach to patient care, and in particular, the invaluable role of the pharmacy team, which is often overlooked and undervalued. Although it analyzed a short-term outcome, the potential cost saving, which can be achieved through the reduced length of stay, far outweighs the cost of setting up the service. As a result of dedicated pharmacy input preoperatively, patients' comorbidities are optimized before surgery, taking the pressure of primary care and ensuring that interventions are acted upon prominently. This may have an impact on patients' sequential of life and general practitioner work overload, both pre and post operative. So in conclusion, the result of this study reaffirms the importance of a holistic and multidisciplinary approach to patient care with a positive effect of dedicated pharmacist input through the patient journey, starting preoperatively until this discharge post-surgery. Further, this study is needed to validate our findings, the findings, ideally in the form of post uh, prospective randomized control trials. So this is like the only limitation with regards to this surgery, in which the patients um, were not randomized. The results were just compared to the expected length of stay that were taken from the national registry. So it would have been better if this article or this study could have been done in a randomized way, where there can be an actual data or actual reduction seen uh, from like those surgeries. Uh, so um, So just what I wanted to say is like in conclusion, this just shows how much of an importance the pharmacist or the surgical pharmacist can make with regards to optimizing the patient's treatment or regime, and how much of an impact the pharmacists have on reducing the cost, providing a better safety and efficacy for those undergoing surgeries. What is significant about this study is the fact that it shows a real life, I mean, close to real life uh, data that shows the importance of the clinical pharmacist, or this new novel innovative term used now, which is called the surgical pharmacist. And with this, I come to the end of this journal club. Thank you all for listening, and I apologize for the inconvenience that happened yesterday. And if you have any questions, you guys are more than welcome.
Mohammed, I have one question actually, like more of a doubt actually. Like, who can, like, who is a surgical pharmacist actually?
So the
Like,
surgical
we know who is clinical pharmacy and who is community pharmacist, and we know that different
Mm,
roles and different
mm,
people who can play that role. But
mhm.
who is a surgical pharmacist is what my question is.
As per this study, the Osmos service is provided by a specially like this pharmacist is just given the role of following up patients who will be undergoing surgery. So once they identify the patient who is like said to be having to go for a surgery, the pharmacist will be following the patients starting from pre-operatively, then peri-operatively, and post-operatively. So, like I said, it's a new approach that was like started in the UK. And in this study, you just can see how much of the so-called surgical pharmacists have an impact on all the like terms that I have mentioned earlier. So I hope that clarifies your doubt.
So it's same as like a clinical pharmacist following a patient from beginning to the end of the surgery.
Yeah, but the surgical pharmacist is exclusive to those who will be undergoing the surgery. So basically, what you'll be doing is like it's the same role as the clinical pharmacist, but like the difference is you will try your best as a surgical pharmacist to optimize the patient condition pre-operatively, as it affects the patient condition during the surgery and post-operatively. And when it comes to the period, like I said, that comes around the surgery, which is the perioperative period, in that period as well, you will be looking at the patient vitals, trying to optimize the PB, and trying to make sure that the patient is taking the surgical prophylaxis And here also comes into the picture the role of the pharmacist when it comes to steroid stress dosing. I have discussed this concept before. So you will be trying your best to look at the patient history and come up with the best dose to avoid any hypotension episodes during the surgery. And post-operatively, you will be basically following up with the patients uh, uh, with the main focus on optimizing the patient condition and vitals and prevention of the like infection. I
Oh,
hope that clarifies your doubt.
yeah. Yes.
So, do you guys have any other questions? Hello. I hope.
Students, is there any more points to discuss?
No, ma'am.
Okay.
Okay. So, shall I stop sharing?
Yeah.
Okay. I'll just stop the recording and stop sharing.